So good afternoon, dear colleagues. Please let me introduce my PhD topic, which is about the effects of maternal factors on the development of orofacial clefts. My name is Márton. Currently, I'm a fifth-year dental student here at Semmelweis University. The two of my supervisors are Gábor Varga and Gábor Gerber, and my SMS is Bianca Golzio. So my vision is to decrease the incidence of orofacial clefts and improve the patient's quality of life. And my mission is to indicate which maternal risk factors play a role in orofacial cleft incidence through the newest scientific data. So currently we have two ongoing projects now. First one is about investigating the effects of deleterious habits and maternal health disorders on the risk of orofacial cleft development. It is a systematic review and meta-analysis. So we know that orofacial clefts are quite common birth defects with an estimated worldwide incidence of around 1.7, 1.8 per every 1,000 live-born babies. And these babies born with these types of anomalies, feeding difficulties, they are often developing conductive hearing loss, they have speech problems, several dental anomalies, and associated social and psychological issues. And we know that maternal diseases during the first trimester of pregnancy are shown to play a role in the development of orofacial birth defects. So that is why our aim in that project is to identify those maternal factors that increase the risk of orofacial cleft development. Our clinical question is that do maternal health disorders and deleterious habits during pregnancy increase the risk of the development of orofacial clefts? We use the PEO framework where our population is pregnant women. We investigated the exposures such as maternal risk factors like smoking, alcohol consumption, hypertension, obesity, and diabetes. And our investigated outcomes is prevalence of cleft lip and palate and cleft palate only. Our hypothesis is that some maternal health disorders and deleterious habits during pregnancy increase the risk of orofacial clefting. And why is it important? Because using our results, these orofacial clefts will be diagnosed to a greater extent, and the mothers in the first trimester will be more actively treated in order to prevent these orofacial clefts. Here you can see our systematic search. It was done in three databases on the 18th of November 2022. And after the flowchart selection, we have 64 eligible full texts. Here you can see our investigated outcomes. And the first figure is about the effects of diabetes on the development of orofacial clefts. Here, in that analysis, we compared those mothers living with type 1 diabetes versus those who are not. We calculated odds ratios with a 95% confidence interval, and we used three subgroups according to the type of the cleft. So the first part is the cleft lip and cleft palate. The second one is the cleft palate only, and the last one is not defined, where the included studies did not mention anything about the cleft type. And as you can see below highlighted, our overall odds ratio is 1.75, which means that in case of clefts, in the cleft group, the number of smoking mothers was significantly higher than in the control group. The second figure is about the effects of underweight on the development of orofacial cleft. Here we also use the three subgroups just as mentioned before. And overall, our odds ratio is 1.21, which is also statistically and clinically significant. And the third figure is about the effects of smoking on the development of orofacial clefts. Here we compared mothers smoking during pregnancy versus those who are not. In that case, we used two subgroups according to the type of smoking, such as active and passive. And due to the size of this forest plot, I divided into two slides. So in that you can see only the active smoking with the odds ratio of 1.28, which is statistically not significant. But in the second part, when you can see the passive smoking, our odds ratio is 1.5, which is both statistically and clinically significant. And it means that in case of cleft babies, the number of the smoking mothers was significantly higher than in the control group. The fourth figure is about the effects of obesity on the development of orofacial clefts. In that case, we used three subgroups according to the different BMI indices. And the third subgroup is also not defined, where the included studies did not mention anything about the BMI index. And our overall odds ratio is 1.31, which is actually statistically not significant, but clinically it is. So the strengths of our study is that we use subgroups according to the cleft type, which is unique comparing to the previous meta-analysis. We investigated more exposures, and we have relatively high population. Although we have some limitations as well, in some cases we have low number of articles and high risk of bias in some cases. In conclusion, we can say that diabetes, underweight, and smoking significantly elevate the risk of cleft development, and which is also interesting that, as you can see before in the forest plot, passive smoking is just as harmful as active smoking. The implication for practice is that, for example, nutrition, plasma glucose levels should be carefully monitored during the pregnancy, and more effective prevention programs against smoking are needed. And the implication for research is actually what might be the difference between the development of cleft palate only and cleft lip and palate, and more investigations needed on the synergistic effect of these exposures. Here we can see the status of our manuscript. We are nearly done. We have just need a little work on the supplementary material. And as you can see, our targeted journal is the Journal of Dental Research with the impact factor of 8.2, and it is a D1 journal. So let's move on to my second project, which is about investigating the effects of pharmaceutical therapies during the pregnancy on the risk of orofacial cleft development. It is also a systematic review and meta-analysis. So we know that, for example, 14% of pregnant women filled at least one prescription for an opioid analgesic during the first trimester in the USA. And we know from the literature that, for example, the odds ratio of developing cleft after the use of anti-epileptic drugs is 6.6, which is quite high. And maternal corticosteroid use was associated with increased risk of cleft lip with or without cleft palate. And our aim in that project is to identify those medications that might increase the risk of orofacial cleft development. Our clinical question is that do medications during pregnancy increase the risk of the development of orofacial clefts? We also use the PEO framework just as before. Our population is pregnant women. We investigated the exposures like medications such as antibiotics, anti-epileptic drugs, steroids, opioids, and folic acid. And our outcome is a prevalence of cleft lip and palate, and cleft palate only, just as in the previous study. And our hypothesis is that some medications during pregnancy increase the risk of orofacial clefting. And it is important because just to identify those medications that should be avoided during pregnancy, and the clinical implication is that to decrease the incidence of orofacial clefts overall. Here you can see our systematic search. We also use these three databases, and the search was done on the 2nd of December 2022. As you can see, we are in the early phase of this project since we have been focusing on the first project and the first manuscript. And just to summarize, you can see the two of our ongoing projects. The planned submission date for the first one is this year, July, and the planned submission date for the second project is this year, November. And I would like to thank you for your attention with the quote of Louis Pasteur: "Science knows no country because knowledge belongs to humanity and is the torch which illuminates the world." Thank you for your attention.
Thank you for your presentation. I would like to ask if the diabetes, the type 1 diabetic patients for the cleft palate, have you examined if they were well-controlled patients or with insulin, or only controlled patients, or is there a difference?
Yes, thank you for the question. Actually, this is a quite interesting question. The problem is that these registries and case control studies which we analyze did not mention anything about whether it is well controlled or not, only just type 1 diabetes, type 2, and gestational diabetes. But it would be also an implication for research to investigate that question.
How did you categorize the hypertension patients? Did you have according to stages, or did you look at the values of systolic and diastolic blood pressure?
Thank you for the question. We didn't make subgroups according to the different types of hypertension. We just stated that those mothers suffering from essential hypertension. But that could be also an implication for research, that whether the systematic and systole or diastole hypertension, how could it affect the development of hyperfacial cleft?
I would like to know, how did the authors or your statistics manage the confounding factors to evaluate the influence of these factors like diabetes and so on, these risk factors. Is there any adjustment? Is there any consideration for confounding factors?
Yes, thank you for the question. It is a very good question. Yes, so in the studies which we analyzed, we found several confounding factors due to the case control studies. And the problem was that in several cases, these case control studies calculated adjusted odds ratio. But the problem was with that, that they did not adjust it to the similar factors. So that's why we included and analyzed only crude odds ratios.
Basically the crude ones?
Yes.
Thank you.